My name's Ilana Gareen. I also have lots of data which are available for master's students to use, and you'll hear about the projects and decide if it's something of interest to you. I'm actually on the 7th floor in the Center for Statistical Sciences, so I'm a little bit different. I'm a little out of the way, but it's a cool place to be, and there are a lot of statisticians to work with there too. So when I was a grad student, I was really interested in the impact of new technologies on human health, whether that be in terms of benefits or in terms of iatrogenic consequences, meaning bad things that happen when you're trying to do good things. So my dissertation work was on reproductive epi, looking at cesarean section and intrauterine devices. And I transitioned when I came here to a postdoc on diagnostic imaging research. So while I was doing that postdoc, I was invited to work on a new lung cancer screening study. And in 1999, there was no recommended screening for lung cancer. Some docs would send their heavy smoking patients, because you know that smoking is strongly associated with lung cancer, to get annual chest x-rays. And this is an example of a chest x-ray. And that is a lung cancer on the chest x-ray. But as you can see, that's a really big cancer, and a chest x-ray is pretty diffuse and hard to look at and will only pick up fairly advanced lung cancers. So by the time they picked up the lung cancer in patients, the horse had left the barn and the patient was stage 4, expected survival at 1 year, 15%. So 85% of people would have died at 1 year. So in 99, a group at Cornell, led by Claudia Henschke, came out with a paper saying, don't use chest x-ray, use spiral CT. So chest x-ray is a flat film, takes an image this way, sometimes an image this way, looks for lung cancer. CT takes sagittal sections and looks within each of those cross sections for tiny, small nodules, usually picked up at 4 to 10 millimeters. So you saw the size of the lung cancer in the chest x-ray. This is a lung cancer because it's labeled. In the, I keep these things this way, in a spiral CT. So Henschke said, look, I have 1,000 people. I picked up lung cancer on chest x-ray in about 7. I picked up lung cancer on spiral CT in 22. This is great. It's going to reduce lung cancer mortality by 80%. And some of us who read that paper said, no. Is there a problem here? You don't know what the outcomes are on these people. All you know is you're picking up lung cancer early. You don't know that you can treat the lung cancer well. So the people may be dying at the same point in time. You'll just know about the lung cancer earlier because you picked it up when it was subclinical. And in that time, they may be subject to chemotherapy, radiation, surgery, lots of interventions that are going to make them feel lousy for the time they have. So we proposed to do a randomized clinical trial where people were randomized to either the chest x-ray that you saw earlier or the CT. And we didn't think we'd find a change in lung cancer mortality. Did the study, and at the end of the day, we found a 20% reduction in lung cancer mortality for people screened with low-dose CT versus chest x-ray. And we have a lot of data from this, I'm telling you. Anyone's interested in lung cancer screening, imaging, we have lots of data that have never been touched. And in fact, I now have a grant to look at some of those data. So when you take a big picture of the torso, you're not only going to see the lungs, you're going to see lots of other organs. You're going to see the liver, you're going to see the kidneys, you're going to see the aorta. And this is an example, because it's labeled too, of a renal cell carcinoma. So that you would think is a good thing because you pick up the cancer early, they'll be able to operate, get rid of the cancer, treat the people, reduce mortality. But we don't really know if it's a good thing or a bad thing yet. So what we're going to do is we're parsing the data, and I've got a grad student working with me on this who's doing a terrific job, Stephanie Shee, and we're taking all these comments that were written on these data forms, and we're parsing them into specific abnormalities like liver cyst, suspect renal carcinoma. And we're going to see what the outcomes are for these patients. Did they develop a cancer? Did they die? In the comparison between chest x-ray, where they didn't pick up much, and CT, was the mortality reduced? Because I forgot to mention that not only was there a 20% reduction in lung cancer mortality, there was a 7% reduction in all-cause mortality. And it's the only screening study to ever show reduction in all-cause mortality. And not all of that reduction appears to be due to the lung cancer. Finish up? Okay, so that's one study. I'll just quickly say that we are also doing a study. I have a grant that I'm expecting a notice of grant award any day, comparing screening in the National Lung Screening Trial, screening in the community. And we're going to use a community database to do that. So lots of data, lots of opportunities. Questions?